So today we will start our session with the splitting of S2 heart sound. S2 heart sound is produced during the closure of aortic and pulmonary valves. There are four types of splitting: physiologic splitting, wide splitting, fixed splitting, and the last paradoxical splitting. So what's physiologic splitting is that during normal heartbeat, during normal inspiration, the venous return to the heart increases. This increase in venous return causes delayed right ventricular filling and delayed right ventricular emptying. Since the S2 comprises of two heart sounds, that is A2 and P2. A2 is produced during the closure of aortic valve and P2 is produced during the closure of pulmonary valves. Since due to increased stroke volume of the right ventricle during inspiration, there is more blood that is being ejected out of the right ventricle, and hence pulmonary valve closes late as compared to the aortic valve, which is closed after the left ventricular filling at its normal pace. So this causes a normal delay between the A2 and the P2, and this is known as physiologic splitting. However, there are certain conditions in which there is wide splitting, that is, if normal splitting, for example, is 2 seconds between A2 and P2, and if this increases to 4 seconds from 2 seconds, that is wide splitting. So wide splitting basically means that the P2 is closing more delayed than the normal amount it is required to be, such as it occurs in conditions such as right bundle branch block and pulmonary stenosis. Then we have the fixed splitting. Fixed splitting is a condition in which A2 and P2 both closes simultaneously. This is seen if the volume in the left ventricle and right ventricle equalizes, and this occurs in one classic condition that is known as atrial septal defect. Since during atrial septal defect, the pressure between the left atrium and the right atrium is equalized, the both ventricles fill simultaneously, and since both ventricles are filling simultaneously, both ventricles eject the blood at equal rate, and therefore there is closure of A2 and P2 at the same time. This is known as fixed splitting. Now what's the paradoxical splitting? Paradoxical splitting is the reverse of the normal splitting. That is, during normal physiologic conditions, P2 closure is delayed than the A2 closure. However, if the condition is reversed, such as A2 closes more late than the P2, then this is known as paradoxical splitting. Then auscultation of the heart sounds. So we need to be aware of where can we hear the aortic, pulmonary, tricuspid, and mitral stenosis sounds. How do we know which valves are present there? So you need to remember the four basic areas, that is the aortic area, the pulmonary area, the tricuspid area, and the mitral area. So on mitral area, you hear three types of murmur. One is this hollow systolic murmur, then there is a systolic murmur, and then there is a diastolic murmur. So mitral area is present at the fifth intercostal space. Then we have the tricuspid area. Tricuspid area is present at the third intercostal space lateral to the sternal border. The pulmonary area is present on the left second intercostal space, and the aortic area is present on the right second intercostal space. Types of murmurs, one of them is the systolic murmur and one is the diastolic murmur. So whichever murmur is produced during the systolic phase is known as the systolic murmur, which murmur is produced during the diastolic phase is known as the diastolic murmur. So what murmurs are produced during the systolic phase are basically those murmurs which are produced or aggravated when the heart is pumping. So when the heart pumps, the blood is ejected from the heart, and this ejection of blood, if occurs through the abnormal valves, then this causes the systolic murmur. Then we have the diastolic murmur. So diastolic murmur is produced during the ventricular filling phase. That is, when the ventricles are being filled with blood and the blood is not being ejected from the heart. In order to understand these concepts of murmur, you need to be aware of the four areas of the heart where you can auscultate these murmurs. So first of all, the right intercostal space, the aortic area, there you can hear the murmur of aortic stenosis. In the pulmonic area, you can hear the murmur of the pulmonary stenosis. In tricuspid area, you can hear the murmur of the tricuspid regurgitation or tricuspid stenosis, and in the mitral area, you can hear the murmur of mitral regurgitation or mitral valve prolapse or mitral stenosis. So these are some of the main words that you need to have the basic understanding of. So first of all is the standing or valsalva maneuver. In this manner, the preload is decreased, and decrease in preload causes decrease in the flow of blood out of the heart. So most of the murmurs decrease with this maneuver since there is no more blood to flow from the heart. There is decreased amount of blood that is flowing out of the heart. Since there is decreased blood flow out of the heart, this decreases the intensity of the murmur. However, passive leg raise causes increase in preload and it increases most of the murmurs. Likewise with the squatting. Squatting also increases preload and this also increases most of the murmurs. Then the hand grip and the inspiration. So during inspiration, we that during normal inspiration, there is normal increase in acetylene into the right atria and right ventricle. So the right-sided murmurs are increased with the inspiration. Then we have the hand grip. Hand grip increases the afterload. So increasing afterload increases most of the left-sided murmurs such as aortic regurgitation, mitral regurgitation, and ventricular septal defect. Now to understand the diastolic and the holosystolic murmurs, first of all, what are the systolic murmurs? There are four types of systolic murmurs. First of all, it's the aortic stenosis. Aortic stenosis is a crescendo-decrescendo systolic ejection murmur with a soft S2 click. This you need to differentiate from the pulmonary stenosis where there is a hard S2 sound that is heard. So during aortic stenosis, the left ventricular pressure is greater than the aortic pressure during systolic, and it is heard loudest at the heart base, and it radiates to the carotid. This crescendo-decrescendo systolic ejection murmur is also known as pulsus parvus et tardas. That is, the pulses are weak with a delayed peak. It can lead to syncope, angina, and dyspnea. That is a classic triad of these three symptoms. It is due to most It is most commonly due to age-related decalcification in older patients, that is more than 60 years old, or it can occur in younger patients if there is some early onset calcification or bicuspid aortic wall. Then the mitral or tricuspid regurgitation produces a holosystolic high-pitched blend murmur. That is, it is the holosystolic murmur present throughout the S1 to S2. It is heard loudest at the mitral area, and if there is tricuspid regurgitation, it is heard loudest at the tricuspid area. Tricuspid regurgitation is commonly caused by right ventricular dilatation. However, rheumatic fever and infective myocarditis can cause either mitral regurgitation or tricuspid regurgitation. Then we have the mitral valve prolapse. Mitral valve prolapse is basically a late systolic crescendo murmur with mid-systolic click. It is due to sudden tensing of the chordate and line as mitral leaflets prolapse into the left atrium. It is best heard over the apex and it is loudest just before the S2. It is usually benign, but it can be predisposed to infective myocarditis, and it can be caused by lysomatous degeneration, such as connective tissue disorders in Marfan syndrome or Ehlers-Danlos syndrome. Then you have the ventricular septal defect. Ventricular septal defect is basically a defect in which the septum between the right and left ventricular is not fully formed, and it causes holosystolic, harsh-sounding systolic murmur. It is loudest as the tricuspid area. Large VSTs have a low intensity murmur because there is large gateway to pass the blood, and since there is more gateway to pass the blood, there is less difficulty in flowing of the blood, and it causes a low intensity murmur. However, small VSTs can cause a high intensity murmur. We have diastolic murmurs. So we have diastolic murmurs of aortic regurgitation and mitral stenosis. Aortic regurgitation produces a high-pitched blowing early diastolic decrescendo murmur. Decrescendo decreases in intensity. Best heard at the base or left external border. Long diastolic murmur, hyperdynamic pulse, head bobbing when severe and chronic. So it causes a wide pulse pressure. A pulse pressure is the difference between the systolic blood pressure and the diastolic pressure. And the causes of aortic regurgitation include bicuspid aortic wall, endocarditis, aortic root dilatation, or rheumatic fever. Then mitral stenosis. Mitral stenosis also called diastolic murmur. It follows the opening snare. Delayed rumbling mid-diastolic murmur. There is an interval between the S2 and O is correlates with the severity. As the distance is shortened, the severity is increased. often a late sequel of rheumatic fever that is chronic mitral stenosis can result in pulmonary congestion, hypertension, and left atrial dilatation, which can predispose to atrial fibrillation and Ochsner syndrome that we heard in our embryonic sections. Then there is continuous murmur, a murmur that is present in the diastole as well as the systole. It is a classic murmur of patent ductus arteriosus, which causes a machine-like murmur, and it is best heard at the left infraclavicular area. It is loudest at age 2, and it is often due to congenital rubella or prematurity.